Good morning, everyone. In contrast to the others, I'm going to show a diagnostic technique and a tip so you can carry
This
home
video
to remember.
demonstrates
Can I
the
have
use
a
of the
volume, please?
anterior segment OCT for pediatric cataract surgeons. ASOCT can be used as a table mount machine or the integrated intraoperative OCT. An easy way to remember the indications is by the word OCT. O is for opaque. When the cornea is opaque in the setting of a dystrophy or scarred due to trauma, OCT helps in diagnosis. C for capsular abnormalities like plaques, fibrosis, and defects in the posterior capsule. When seen on OCT, makes us better prepared. T for total cataracts, where fluid pockets as well as integrity of the capsules can be made out. Note how the scan passes from nasal to temporal end, demarcating the area of dehiscence and herniation of contents in vitreous. Dry aspiration and low settings in these cases leads to a successful surgery. For a safe pediatric cataract surgery, remember OCT. Thank you.
So first of all, it's very difficult to acquire OCT in such a child, making him, I don't know how would you do it like pre-operatively? How do you do the ASOCT for such small children?
Thank you for that question. I totally agree it's very difficult, but with the newer swept source machines, it's taking a scan in 3 seconds. So we are either straddling the baby in a butterfly position or making this baby upright. And we also have intraoperative. I know it's a cost involved, but if you have access, I think it's an add-on tool, complementary to your examination.
So does it help in planning the posterior capsular rhexis or anything? Does it help in the surgery, like any step of the surgery which it can make easier for the surgeon?
It is very useful for the posterior capsular rhexis.
Apart from diagnosis,
Yes, apart from diagnosis, it's the only technology that can actually look at the vitro-lentil interface.
Yeah.
So vitro-lentil interface in a child, especially the Burgess space, you can anticipate a difficult capsular rhexis, the posterior capsular rhexis. It's not that tough for experienced surgeons, and we have been doing it without the OCT for years. But if a novice surgeon is doing it and you have the OCT, you can actually see the attachments of the Burgess space, and you can anticipate whether you can do a rhexis or better put an IOL and then do a rhexis. So I think that is a change in step that I do before.